Start.
Okay, all right. Well, welcome everybody to today's Ask the Expert webinar. We will be reviewing findings from one of the trials that we worked on and recently was published. It's a randomized multi-oral immunotherapy with Omalizumab real-life study. And we have a special treat because we have Dr. Maria and Stacy, who led the study at UCLA, our sister site for this trial, and they will be participating today as well and sharing their insights of OIT. Hi, Maria.
Hi, Tina. Hi, everyone, whoever it is now and whoever is going to join later. We're very, very happy to be invited to this event.
Hi, Stacy.
Hi, Tina. Hi, everybody. I can't see who's on here, but I'm sure some of our families that participated in the trial are hopefully joining us.
All righty. And this webinar is being recorded, so we will share it with folks who participated or were interested. And so even if someone's joining late, hopefully they can watch it later if interested. Okay, so what I wanted to go into was why was the study MIMIX done? And the reason behind it is that even though we have done several studies that shows that oral immunotherapy is effective, we still don't completely understand the underlying immune changes that occur with oral immunotherapy. And what dose is the perfect dose? And how long do we have to continue doing this? And, for those who have a lot of reactions or adverse effects or kind of side effects from OIT, if we lower the dose, is it still going to be beneficial? So trying to understand all these different factors that go into OIT will help us understand how we can provide better patient participant-centric care, because not every food allergic individual is the same, and the treatment we offer should take into account that person's unique kind of challenges and experiences with OIT. And so that's why kind of MyMix was designed with UCLA and Stanford based on our own kind of patients' experiences in mind. And in this study, what we attempted to do was have varying doses of different allergens in a multi-OIT study, and then looking at the immunological changes at baseline at the start of the trial, and looked at what happened after 18 weeks of therapy and whether there was a notable immunological change that was achieved with low-dose immunotherapy. So it was a trial, a phase 2 trial that we did with UCLA, and this was considered, this is considered a novel participant-centered trial because we took participant experiences into account and we did away with oral food challenges. We strictly relied on IgE testing, skin prick testing value, and prior history of reactions, and we used the changes in the immune response as a marker for whether this is going to be successful or not. And we did away with oral food challenges because I'm sure if any of you have been involved in those, it is not a pleasant experience for the child, the family, or whoever's undergoing them. And so I'd like to have Stacy kind of go through the next few slides and tell us how the study was performed.
So hi everybody, I'm going to talk a little bit about the study design. So we included participants ages 2 to 25. We enrolled a total of 60 participants with 30 at Stanford and 30 here at UCLA. The allergens included in the study were the 13 most common allergens, which are peanuts, the tree nuts, almond, cashew, hazelnut, walnut. We had salmon for the pink fish and cod for the white fish, shellfish, egg, milk, sesame, soy, and wheat. And the participants could have any combination between 2 and 5 of those allergens included in the therapy. So they could have, peanut and a tree nut, or milk and egg, any combination between 2 and 5 allergens for the treatment part of the study. Okay, next slide. So the study involved, there were 3 parts to the study. There was a screening phase, And then when patients were randomized, all participants received 3 doses of Omalizumab, which is Xolair, which is given subcutaneously by injection. Every participant received 3 doses of 150 milligrams spread apart once every 4 weeks. And then they started the multi-food oral immunotherapy part of the study. As I mentioned, with the most common allergens. And then at week 18, we drew their blood. There was a baseline blood assessment at screening and a blood draw at week 18. All of the participants were randomized to one of 2 groups. So half of the participants were randomized to a low dose food allergen group. And half of the participants were randomized to a higher dose. So the low dose group received a total of 300 milligrams total protein of their allergens at maintenance. And the higher dose group received a total of 1,200 milligrams maintenance total protein of their allergens. So here you can see we screened a total of 65 participants, and of those, 60 went on to receive treatment in the study. Let's see, there was group A, as I mentioned, with 30 participants, and the lower dose group receiving 300 milligrams daily of oral immunotherapy total protein, and the higher dose group, as I mentioned, received 1,200 milligrams daily maintenance dose of their allergens and total protein. Next slide. By the way, this was a double-blind study. Neither the participants nor the study staff knew which group the participants were assigned, whether it was the low dose or high dose group. So here you can see in the chart, there was the screening phase where we confirmed eligibility and did a blood draw. Then they started with their Xolair injections once every 4 weeks. And then when we got to week 0, they had their 3rd and last Xolair injection, and we started the multi-food oral immunotherapy. All participants started at 5 milligrams at a low dose. And then the low dose group, group A, increased 4 weeks later to 60 milligrams of total protein of their allergens. And then 4 weeks later, they increased to 300 milligrams total protein of their allergens. And the high dose group also started at 5 milligrams, which is a low dose. And then we increased them to 240 milligrams 4 weeks later. And then up to 1,200 milligrams was the maintenance dose, the higher dose. Okay, next slide. So I will hand it over to Dr. Garcia-Lorette to talk a little bit about the participant characteristics.
Okay, so hi to everyone. Well, as you can see, you know, the population came from many places, you know, Southern California being a very kind of mixed population kind, but most of the kids were, you know, between ages of 4 to 20, and the average age, if you see, ends to be in both groups, age 10. So I'm sure you know, for the attendees, you hear, you know, that was my kid, was one of the many kids, the 10-year-old kids that we had. As we expected, because allergies don't come alone, 2/3, you know, or more of the kids had other atopic conditions. You know, food allergy that's usually not develop on its own. It comes with, you know, part of what we call the atopic triad. So some kids, you know, had a history of atopic dermatitis. Some kids have a history of asthma, some of allergic rhinitis or seasonal allergies, and some of the 3. The numbers that you see, you know, on the side of the screen, many are very, very small, but overall what it says that the participants in many ways had common characteristics of being atopic, and food allergy being just one of their allergic manifestations. And we go to the next slide. And this is something that won't come as a surprise. As expected, most of the kids, all the kids had more than one food allergy, and that's the reason, in fact, behind many of these studies, to be able to address more than one allergy at the same time. And as expected, peanut was by far, even if it wasn't necessarily to be included as one of the allergens, peanut allergies by far, in anyone over the age of 2, the most common. So the distribution both in the high dose and the low dose was equal, but the foods that you chose, it were the parents that chose to include the various combinations of food. In both group included peanuts in a large number of participants, and then in decreasing order, cashews and walnuts and sesames, the usual suspects. And it also not unexpectedly, shellfish, that is one of the common allergies in this group, it's usually not a problem. And that's why it was both fish and shellfish as a proportion were included in fewer cases, in fewer of the mixes. And now, I'm going to pass it on to Tina, that is going to tell all of us, what happened. This is the part where we tell what happened. Are you there, Tina? There she is.
I am. When I share my screen, I can't find where my mute button and my camera button are. So just having some driver's seat jitters there, I suppose. But so exactly, our Mymix paper and findings were published in January in the journal Allergy, which is very exciting. So it is our work that we've done is much widely disseminated now, and we can share our findings. So essentially, in terms of safety, we found consistent with our other trials that it was actually very safe. We didn't see a lot of notable scary events. As we see with our other food allergy trials, the majority of symptoms were gastrointestinal. So this captured nausea, vomiting, tummy aches and pains, and 15% of doses were associated with gastrointestinal concerns. Whereas, breathing and skin findings like hives were in much smaller percentages. And then what else? The other aspect that was notable here, the other finding that was significant, was that when we looked at numbers from patients who were receiving 1,200 milligrams versus 300 milligrams, we found that their moderate symptoms, meaning it's not mild, just a little more severe, not severe, so in the middle, was slightly higher in the 1,200 milligram group. So the higher the total maintenance dose was, they had a slightly higher rate of moderate symptoms compared to those who were in the 300 milligram dosing group, which is consistent with what we were expecting to find. And that's actually one of the reasons for the study. The higher the OIT dose, even though it gives you protection against larger amounts of accidental exposures, it also brings in a risk for more side effects and symptoms. So we're always trying to find what is the sweet spot of minimizing symptoms while still achieving efficacy from OIT. And so that's where I just want to switch gears a little bit on because we did away with food challenges, kind of what we were hoping to find. So in this study, the change in the immune markers in response to OIT was what we were looking for after 18 weeks of therapy. So it was considered to be a proxy for response to treatment with OIT. And we chose to do this because some of our other trials like MTAX and MAPEX showed that participants who passed their exit food challenges, like over 95% of those who passed their food challenges showed an increase in these immune markers. And this was specifically the ratio of IgG4, specific IgG4 over specific IgE. And when we say specific, we mean allergen specific. So we're checking for peanut IgE and IgG4 or cashew IgE and IgG4. So the primary endpoint of this study was to see if dosing with OIT in these different dosing groups can induce a change of more 25% or more in the specific IgG4 IgE ratio in at least 2 allergens. So we obtained these labs at baseline and then again at week 18. And IgG4 is, we consider it our protective antibody. So during OIT, we get higher levels of IgG4 and it blocks, when you have exposure to allergen, it actually competes with IgE antibodies. So it provides a protective effect. So we want to see higher numbers for the specific IgG4. So in our findings, we saw that 70% of all our participants showed this increase in just 18 weeks of therapy. So we were able to find greater than 25% increase in the IgG4 and IgE ratio in at least 2 allergens. And both groups were equally successful, which is very exciting. And then this graph on the end kind of showed that we tried to dive in deeper into each allergen and the dose that each participant took, because this was it was each participant had a different concoction of what they were being treated with. A person who was getting 2 allergens in their mix had higher amounts of each allergen versus someone who was getting 5 allergens in their mix, because the total had to be either 300 or 1200. They were getting less amounts of each individual allergen. And what we found is 18 weeks of therapy, even the lowest amount of allergen was still inducing an immune change. And we dived in deeper because, we're looking at the ratio IgG4 and IgE, and it is known that in the first several months of treatment with OIT, we actually see a slight rise in IgE. So we were expecting to see that. So when the ratio was increased, we wanted to see what was driving this change, and it was IgG4 that was actually driving this change in ratio. So even in 18 weeks of therapy, having OIT induced a change and increased the number of our protective IgG4 antibodies in both groups. And we looked at not all the foods, just because, as you saw from the numbers of allergens, peanut, cashew, and walnut was what was most represented in the allergens. So those were the 3 we looked at, just so we could say with certainty whether this was a significant change or not. So we looked at peanut, cashew, and walnut, and in all 3 of them, IgG4 was the one driving the change in ratio. Another analysis we did is called a time to maintenance. And we do this analysis because it helps us calculate the time it took each person to achieve maintenance dosing. And we kind of use it as a proxy for adverse events or difficulty with dosing. For instance, if someone's having a lot of reactions, even if it's mild, we tend to back off on the updosing. So they might be on a lower dose for longer, which means they might get to time to maintenance a little later than someone who did not have any problems throughout the study. So that's part of the reason why we do time to maintenance calculations in all our OIT studies. And we found that between the 2 groups, the time to maintenance was not significantly different, which means that the higher dosed groups were not having more difficulty than the lower dosed groups, which was reassuring. Also, time to maintenance was not affected by the number of allergens in the oral immunotherapy mix. And now another aspect of this study that we are actually really excited about and need to build upon further is kind of what happened. Like, we had 60 participants who were part of Mymix. We are part, between Maria's group and our group here at Stanford, we have so many clinical trials where patients are being treated, but we don't have a lot of data on what happens to them afterwards. Like after the clinical trial, how are they doing? Are they still dosing? Were they able to go up? Did they go down? Did they open up their diet? How have their adverse events been? How has safety been? So we just don't have a lot of data on long-term efficacy and adherence. And because better understanding of kind of how folks are doing 2 years from now, 5 years from now, will help us provide better care and trying to understand what barriers may come up down the line so we can better prepare our families and ourselves of things to watch out for. So to better understand that aspect, after completion of the MIMIX trial, we attempted to characterize the real life experience from participants collected through surveys. And we did it only presently just for, out of convenience, we did it just in the Stanford cohort for now, but we are hoping to collect this data from the UCLA group as well. And we conducted surveys that looked at kind of asked questions about ongoing dosing, reactions, epinephrine use, and then additional surveys to assess quality of life. Because at the end of the day, if daily dosing is inducing more stress, it may not be worth it. And it's important to look at the psychological effects of OIT as well, and whether, the burden of treatment offsets the, benefits you get from OIT. So we reached out to 30 participants within Stanford, and among them, 21 participants went ahead and filled out the data. And we found that 15% of the patients continued all of their OIT food. We did identify that 5 patients stopped dosing, 3 stopped because of reactions, and 2 did not give us the reason behind why they had stopped. There was 1 patient who reported needing epi from an accidental exposure, but other than that, we had no other OIT caused reactions worth reporting. And then we also looked at quality of life, and the majority of participants who filled out the survey actually reported extremely positive outlook from the OIT treatment. And over time, we looked at kind of at the end, at baseline, what the burden of treatment was at the end of the study, and then 2 years later, and we found that the parental burden and the burden of treatment actually decreased, suggesting an improved quality of life and being the ability to incorporate the dosing as part of their daily routine and life. So these were all very positive overall results. And again, there were a few folks that did not continue seeing the benefit. And it's also through these questionnaires to understand the why, why were they not able to continue dosing? And once we figure that out, we can try to come up with strategies to minimize that dropout rate. Recording as well, but you can scan the QR code here to access our registry. In the registry, you have to enter kind of your demographics information, like what, best email, contact info about your child, what their allergens are. And then there's a question there about, have you done OIT? And answer yes to that question. And if you answer yes, our data team can kind of filter it based on that question and send out the long-term follow-up questions directly into your account or your email. And just to kind of wrap this up, so the main conclusions from the MIMIX trial is that this was the first of its kind in the sense that it was assessing low maintenance doses for multiple food allergens at the same time. And our findings show that changes in biomarkers are induced much earlier and at a much lower maintenance dose than we previously thought, which is very promising. And this knowledge is going to help us to improve long-term compliance, minimize side effects due to OIT, especially in the setting of multiple foods. And, as Maria mentioned, a lot of our patients, 45% of our food allergic patients are allergic to multiple foods. So studies kind of addressing that need will add a lot of value in the food allergy space. And this is just a puzzle piece that I'm sure many of you have seen before. It just goes through all the different studies our center is doing and the multi-pronged efforts. We're doing studies looking at different allergens, and then we also have 2 prevention studies in the works, and we have some studies that are looking at kind of digital medicine, so telemedicine or Bluetooth enabled, looking at respiratory function. And then we have some studies helping those who are food insecure and helping them with access to allergen-free foods for their family. And so if anyone wants to learn more, this is our website at the very top. If you're kind of curious about what other research trials are going on, or if there's any near you, you can go to clinicaltrials.gov, and all research trials being conducted in the United States have to be registered there. So it's a great way to kind of see what is happening in this space and what else is going on. You can join our registry from this link here. And then, as always, any questions come up, you can email us at snpinquiry@stanford.edu. And that's actually the end of my presentation here. And thank you, to all the participants who are on this webinar now, who have participated in a trial. All the time and effort and challenges and injections you have gone through has helped us push the field forward and help many more families. And of course, our collaborators, UCLA, Maria and Stacy, thank you for all your help in helping us with this study and many more. So I will go ahead and stop share. And we can go through the questions. Maria, did you want to add some of your insight from the trial and any words of wisdom? And she promptly runs away. No, I'm just kidding.
Well, I think, Tina, that this collaboration, for us was kind of like critical for our patients, for the patients in Los Angeles, maybe to work with your group and have that support. It was very inspiring, I think, for the efforts that we have pursued in other clinical trials, plus what we're doing as clinical OIT. And I think for those parents that stuck with us, and you know who I'm talking about, the many families I saw in your participant list that I recognize the last name, their participation was really critical for them and for the kids that are coming after, because, this study really addresses the reality of oral immunotherapy, that it is, which is the minimum amount of allergen that you can give the kid across several allergens that keeps them out of trouble. Different protocols use different things, but what you were able to show that 300, the famous, magical number of 300 milligrams of protein keeps you away from, from having a severe, anaphylactic reaction. Yeah, I think it's, nobody has published the same way that you've done it. And this was, thank you to very well thought clinical trial that had these two arms. So we use that now to help more kids in more situations to try to minimize the risk. The trial that we have going on now with more than one biologic is going to be even more helpful. And I think we are on our way of curing food allergy, or at least alleviating to the point that it's not a problem. So, that's what I have to say, and to thank all the participants, all the families, all the kids that came and got the shots. I think it's been a tremendous step forward in the management of multi-food allergies.
Thank you, Maria. And then Stacy, any thoughts from you?
I see lots of our friends on here on the participant list. I love seeing many of the families that were treated in our study participating, and then some of our newer families who are undergoing the oral immunotherapy in our current combined study. So I just want to say it's great. Sometimes I get emails or phone calls. We hear from patients who have gone through the multi-food oral immunotherapy. And, I got an email the other day from it was a teenager's mom that the child was on vacation and had an accidental exposure ingestion of a lot of peanut actually, and did fine and had no symptoms, and she was grateful, and they got very emotional. And I love getting those emails and hearing how people are doing, and that they're if they do encounter an accidental ingestion, they're safe, and that they are not having serious reactions, and that they're feeling relieved, and a lot of freedom to, eat out at more places and do more things. So it's great to hear back. And I think the study was really a success at, keeping children, at desensitizing to more than one food. This was the first trial we did here at UCLA with multiple food allergens at one time. We do a lot of oral immunotherapy with single foods, but this was the first one we had done with multiple foods. And it was great. And that really taught us a lot. And has been helpful now in our second trial we're doing now with multiple foods, the combined study, which is a collaboration with Stanford. So it was really great. I'd love to hear, I don't know if we have a couple questions here in the chat.
We do. They're in the Q&A, and I've been trying to answer them. But there was one in particular that I did want to share with everyone, the question about EOE. And this is actually another reason we wanted to explore whether low dose immunotherapy would even induce an immunological change, because in the setting of low dose, going low and going slow are kind of our ways to kind of stave off EOE, or if EOE symptoms develop. So in that setting, knowing how low we can go, or how low is still beneficial from the OIT perspective, but still kind of keeps us away from triggering EOE, is also going to help. We did have one participant who had EOE in the study, but we do not suspect it was due to treatment, because their father was just diagnosed, and they were had similar symptoms for a while, and they got scoped for that reason, not because of new symptoms that had emerged. And also our study, a different study of ours, is doing esophageal string tests, where in the clinic we're having folks swallow a capsule, and then an hour later we're pulling it up to kind of capture inflammatory cells in our esophagus. And we're hoping that this data will help us understand the connection between those with GI symptoms and those that end up developing EOE or don't have EOE, or kind of how they're doing to the treatment as well. And UCLA is part of that study as well, our combined trial. So we hope to get, have more data to better understand this connection with OIT and EOE.
Yeah, one of the things that I wanted to add, that perhaps you said before, but that we are now in what is called maybe OIT 201. The next question is not whether it works, but for a short period of time, which is the minimal amount that it induces desensitization. But the first 3 years are clear. It's the second 3 and the third 3. For all of you who have gone through the our first trial, or MIMIX, the question is now for how long and how much, and that's what that is so critical for the families to be involved in this registry for long-term follow-up. Long-term follow-up is not a year. Long-term follow-up is 3 and 4 and 5. And at what point we call it quits, because at this point we're telling families, for as long as you eat 2 peanuts, you'll be protected for 8 peanuts. But is that ever? That is the question that most of the families that have gone through most of these OIT trials have now. Is it ever going to be enough? And I think that we don't have data, because we don't still have these long-term registries of patients that we continue to follow those biomarkers. They are the forever registries, like they are the long studies, that are done for the breast cancer studies. That's the only way that we can do, is have a registry that follows people, or these patients are patients for a very long time. And that is an answer that we don't have. And when we cannot invent, it has to come for us being committed to follow these patients for 10 years.
All righty. I'm just looking at the time. It's 1:07. I know you have patience, Maria and Stacy. And if some of the folks who have additional questions, please email us and we'll try to get those answered for you. But thank you everyone for joining today. We had at one point, I think 31 participants, which is great.
Mhm.
Thanks, everyone.
Take care.
Bye.
Video.
Okay, I can unmute myself and tell you.